And once again to Moments of Fruitfulness. My apologies for coming to you late. But today we are going to discuss another interesting topic, still following our series on the causes of infertility. We are looking at the ovulatory factors that will lead to infertility. I am your host, Professor Joseph Ikechebelu, Professor of Obstetrics and Gynecology. I'm a fertility specialist. Now, looking at the causes of infertility, ovulatory factors, and remember, we have said that about this time next year, you shall carry your babies, and that's our watchword. But while you go through this series, remember, whatever is your challenge, whatever is your problem, we are here to provide you with a solution. And these are ovulatory factors that can cause infertility. Now, when we look at problems that will arise from the ovulation, the first will be where there is no ovulation. If the ovulation is not happening, then it means that the woman is not producing any eggs or not releasing any eggs. That becomes a problem and it can lead to infertility. In some cases, there may be irregular release of these eggs so that the woman is not aware, particularly when the egg is released. And so she will not be exactly sure when she will have intercourse with her husband to get pregnant. And so this is a problem. There could be also this category of women that will have, will I call it, abnormal ovaries, particularly the atretic ovaries or the ovaries that have not developed as expected. And finally, we could have the category that will have what we call resistant ovaries. We'll look at all these things and give you the solutions. And if you follow the proper medical advice, I'm sure that about this time next year, you will carry your baby. Before we go into the details of these causes, let's look at the pathway for the production and release of eggs in the human body. And we call this particularly the hypothalamic pituitary ovarian axis. When I say hypothalamic pituitary ovarian axis, you see hypothalamus is in the brain. The pituitary is one little organ that produces the essential hormones that control this ovulation. And then you have the ovary, which is we can call it the factory for the production of eggs. That is the ovary. That's the human factory for the production of eggs. It is inside the body, unlike some other animals like the chicken and others. They lay their own eggs and you see it physically. Here in the human, the egg is released inside the pelvis of the woman, so you don't see it. But it happens every month. So in this hypothalamic pituitary ovarian axis, let me explain it to you first. Again, the hypothalamus releases the controlling hormone. So you can actually see that this production of egg is actually controlled by a interchange of hormones. The hypothalamus releases the key controlling hormone we call the gonadotropin releasing hormone. And this hormone particularly is released to stimulate the pituitary, which is the pituitary gland. That's actually a powerful endocrine gland in the brain, the base of the brain, that also releases hormones that control every aspect of the human body. It has the growth hormone that controls your growth. It has your growth. It has the that stimulates the ovary to produce the follicles. So once the FSH is elaborated and the level is increasing, it stimulates the ovary and the ovary produces the follicles. The follicles grow. And as they grow and mature, the luteinizing hormone comes in to luteinize the follicles and bring the ovulation trigger. So that once there is an rise in the level of the luteinizing hormone, it requires just about 24 hours from the rise, then you have your ovulation, between 24 and 36 hours. And so that's why we talk about the combination of these hormones triggering the growth of the follicles and then the release of the egg from the follicles. And that is the job of these two hormones. Of course, once the egg is also released, and even in the process of the growth of the follicles, the ovary also elaborates hormones, particularly the estrogen and the progesterone. There are others, the inhibin and the rest. We will not go into all those details, but remember, estrogen and progesterone is also released from the ovaries. This estrogen and progesterone are the ones that now act directly on the uterus, causing the endometrial lining to change in its nature. Why is this necessary? It's preparing the lining of the womb, it's preparing the uterus to receive the embryo, which is the baby when it's fertilized. The egg, once it's fertilized, it forms the embryo, then it receives the embryo. Very important. And so you can see this hypothalamic, pituitary, ovarian. We can also now add uterine axis. Completes the cycle of what happens from the gonadotropin releasing hormone in the hypothalamus to the pituitary releasing the follicular stimulating hormone and later the luteinizing hormone, then to the ovary causing the follicles to develop and to grow, and then they elaborate the estrogen and progesterone, and then the cycle is complete. These hormones now act on the uterus to develop the endometrial lining, thicken the endometrial lining and prepare it, even the luteinization and every other thing, for it to receive the developing embryo. That is the natural cycle. And this is very important. It happens, and that's why pregnancy occurs. This is another important aspect. That's why ovulation is connected to your menstrual flow. Once this embryo arrives, or once the egg is not fertilized, which means the egg that has been released is not fertilized, the corpus luteum that forms after the egg is released degenerates after 10 days. So once the egg is not fertilized, so there is no pregnancy, the endometrium that has been prepared, waiting to receive the pregnancy, there is no pregnancy. So the corpus luteum degenerates after 10 days, and then the production of estrogen and progesterone decreases sharply. The endometrium is shed, and that shedding of the endometrium is what we see and the woman will notice as menstrual flow. You now realize that menstrual flow is the product of absence of pregnancy. When there is no pregnancy coming into the womb, when there is no baby coming into the womb to plant, then the endometrium that has been prepared will be shed off, so that the new preparation will start. And that's why we call this a cycle, menstrual cycle. So the menstrual cycle is controlled by this ovulation. So it's important that every woman will understand very well her ovulatory cycle, because that's what controls the menstrual cycle. And so we're going to zero into the problems that will arise when this ovulation is not happening as it should. Let me start from the higher center, which is this hypothalamus. We talk about the hypothalamic anovulation when it is as a result of a challenge in the hypothalamic center. That means that the gonadotropin releasing hormone, which is released in a cyclical fashion, if it is not, it means that this whole stimulation coming from the higher center is not working. Situations that can give rise to this would be women who are involved in excessive exercise, low weight, very extreme low weight, and you're wondering what is happening to you that you're not adding weight, inadequate calorie intake, and severe stress, chronic illnesses. That's why sometimes when you are under, women, if you're listening to me, you will know this, when you are under extreme stress, you find out that your menstrual flow will not come for that period. That means ovulation had not taken place that month. This is what stress can do. It knocks off the ovulation. In the same way, chronic illnesses, you are so debilitated and so weak that you can't even do anything, with a lot of weight loss and every other thing. In such situations, the body system is not functioning optimally. Ovulation will also be affected. So this is ovulation challenges resulting from the higher centers. Of course, how will the patient manifest so that you know that this is the situation? There will be absence of menstrual flow. So in any month that ovulation fails to occur, menstrual flow will be delayed. And once that menstrual flow is delayed, the woman will complain. Of course, the first thing for you to think about is to wonder, oh, could this be a pregnancy? And if it's not a pregnancy, what else could it be? So if you do a simple pregnancy test, you find out that you're still not pregnant. It simply means in that particular month, in that particular cycle, ovulation failed and you could not have your menstrual flow. We have several medications that can be used to treat situations like this, when actually is arising from the hypothalamus and every other thing. But we will get there by the time I go to specific treatments that can occur. The next is hyperprolactinemia. Still talking about the higher centers also. When the prolactin is also one of the hormones that is produced. When there is high level of the prolactin, we call it hyperprolactinemia. It has an effect also on the ovulation. And the things that could cause this is if there is a pituitary adenoma. Because the prolactin is produced from the pituitary, we have come down from the higher centers and the hypothalamus to the pituitary level now. And the first challenge I'm taking at the pituitary level is the prolactin secretion. And when there is increased secretion, we have hyperprolactinemia. I just said that increased secretion could be as a result of a pituitary adenoma, a tumor in the pituitary gland. And when that tumor in the pituitary gland is elaborating these hormones more than necessary, that's what we call hyperprolactinemia. It could also be from the use of some drugs, particularly dopamine antagonist drugs, that can actually cause this. And once this is there, what will the woman notice again? The observation will be lack of ovulation again, and then amenorrhea will result. Of course, you will not have your menstruation. Added to this is what we call galactorrhea, because prolactin is the hormone that is responsible for the flow of breast milk. So when the level is high, for a woman who is not breastfeeding, who it's not a woman who has just had a delivery, and then suddenly you, young girl, you start having milk coming out from your breast. That's what we mean by galactorrhea. Milk is your discharging milk from your breast when you have not delivered a child. That is as a result of this high level of prolactin. And what can be done at this stage is to look for treatment. Of course, there are investigations that we usually do, particularly checking at the brain level, to do CT scan of the brain, even simple skull X-ray, coning into the sella turcica. You can actually find out whether there is this pituitary adenoma or not. Once you've ruled out that, the rest of other causes can easily be taken care of, and is to check what else could be the cause. If there are other drugs that are causing it, like dopamine antagonist drugs, is to withdraw those drugs. And the treatment will simply be to use some drugs that can actually inhibit the effect of this prolactin. And we are talking about carbagolin, bromocriptine. These are medications that can actually reverse this. So this is another cause of amenorrhea. We can say it's not so common, but you watch out for it. So a young girl wants to start discharging milk from your breast when you are not pregnant and when you're not nursing a child, then there is a problem. This hormone is high. Do a test, prolactin assay, and the result will show that it's high, and then it can easily be treated. Let me look at the third aspect. Now we are coming down from, we have talked about the higher centers, and we've talked about the hypothalamic and ovulation. We've also looked at factors at the pituitary level, which is a very common one. There is the hyperprolactinemia. Then coming down to the level of the ovary, you can actually talk about, we are looking at two options that can happen in the ovary. One is when we have the ovary, this ovary is normal, but the ovary is not releasing eggs as expected. The commonest of all the conditions we find these days will be the polycystic ovary syndrome. That used to be the name we know it for, but today that name has changed, and a new name is being used now for this particular condition. We now call it polyendocrine metabolic ovarian syndrome. It's still similar, PCOS, PMOS. What is happening here? The ovary has a lot of reserve follicles, but these follicles are not maturing. That's why some people will call it, in those days, we call it resistant ovaries. There are a lot of reserve follicles. So if you check the ovarian reserve by the hormones we use in checking the ovarian reserve, example is the AMH or the antral follicle count, you find that the AMH will be very high. The antral follicle count will also be very high. So the ovarian reserve is there. So all the follicles you have in the ovary remain at their antral follicle stage. And so, but they are not maturing for them to go to the level of release, which we call ovulation. That's what is called the polycystic ovary syndrome or the polyendocrine metabolic ovarian syndrome. And in this situation, how will it manifest? The woman will have irregular periods because what is happening is that the eggs are not maturing. So ovulation is not taking place. And once ovulation is not taking place, the menstrual flow will not come as expected. So after some months, there will be a breakthrough bleeding, and the woman will experience a breakthrough bleeding, and she can count that as a menses. But that's not truly the normal regular menses. And so irregular periods, we can also have absence of menstrual flow. In severe cases, the menses will not even come at all because ovulation is not coming at all. These are the extreme cases of the PCOS or PMOS. And so all the range of absence of menstruation, amenorrhea, or the one we call oligomenorrhea, which means that the menses is coming maybe after 42 days, after 3 months, sometimes after 4 months, before the woman will experience a menstrual flow. What's the treatment of choice? Of course, the diagnosis can easily be made from ultrasonography and hormonal analysis. When you do the hormone analysis, you find out that the FSH, LH, they come in a ratio. The normal ratio is FSH, LH is 2:1. But when this condition PCOS comes in, there is a reversal of this hormonal ratio. Now we have FSH, LH ratio becomes 1:2. So that's a reversal. And so these things, the diagnosis can be clinched easily. And once the diagnosis is made, the treatment here will be to find a way to induce ovulation. There are so many ways we can do that because you want to actually stimulate ovulation. That's the way you can overcome this absence of ovulation. And to stimulate ovulation here, we can use medications to do that. But I will come back to that towards the end so that I will state clearly the steps we take in treatment and getting you to the end result of achieving a pregnancy. Now, we've mentioned this aspect where you have the ovary, good reserve, but still the follicles are not maturing. You can have another situation where we have a diminished ovarian reserve, which is age-related. When we are looking at this as a premature ovarian failure, the ovarian reserve has depleted, and so there is no ovulation occurring again. Women in this category usually experience menopause early. By 35 years or even before 35 years, some of them have stopped menstruation. And so that means that the ovarian reserve has been completely depleted and they've gone into menopause. Of course, before you get to that stage, it starts by manifesting as oligomenorrhea or irregular cycles, and at the end of the day, it ends up. So you, that a woman, the menstrual cycle is important because one of the key indications that you're normal is that your menstrual cycle is coming every month. That means you are ovulating regularly and your menstrual cycle is flowing every month. So when it's not happening, something is wrong. And so this diminished ovarian reserve comes with age. Even when you are not, when you don't have any other problem, every woman, as soon as you're getting to 40 and above, you find out that your ovarian reserve continues to dwindle as fast as possible because you are approaching menopause. There is a particular hormone that we know now that can give us this ovarian reserve accurately, and that hormone is called anti-Mullerian hormone, AMH. That's one of the hormones now that are regularly assessed whenever a lady is having ovulatory challenge. You want to know what a reserve is, and it gives us accurate assessment of the ovarian reserve. And once you have it and the AMH is low, it simply means that the reserve is depleted. If the AMH is high, everything, if it's normal, then these are situations it can help you take a decision whether it's something you can treat or whether it's something you cannot treat. And of course, and this hormone is reliable and it's not influenced by any other factor. You can actually assess it and have it. And of course, the treatment option here will be for you to see what you can do to achieve ovulation if there is still a reserve enough for you to. So ovulation induction again, or if that cannot happen, it's for you to look at alternatives, which is egg donation and the rest of others. We are coming to that so that we can take the treatment holistically. Let me also state that thyroid activity, the thyroid hormones, can actually affect ovulation to a good extent. We are looking at hyperthyroidism, hypothyroidism, because the TSH, thyroid stimulating hormone, comes also from the pituitary, and it also affects the thyroid gland, which will secrete all the other thyroid hormones, T3 and T4. So when you have hyperthyroidism or hypothyroidism, you find out one of the outcomes is menstrual irregularities, either amenorrhea or oligomenorrhea, and it's as a result of the effect on the ovulation. It also can cause anovulation and bring all these things to bear. Of course, the treatment, if it is hypo, is for you to take tyrosine derivatives so that you can build up your tyrosine level, or if it is hyper, it's for you to take the antagonist so that you can bring it down. Let me also mention that there are conditions that can actually affect a woman's ovulation seriously, and that is obesity to a good extent. When you find a woman who has you've added so much weight that you're so obese, that can affect your ovulatory function. So, because it causes some metabolic changes that actually are not good for your regular ovulation. So, managing your weight as a young lady is a very important aspect of your life. Even those who have polycystic ovary that we have mentioned, there are varieties of this polycystic ovary that comes with a lot of weight gain when you have all the insulin resistant components of it. And when this happens, part of the treatment is weight reduction. And when weight reduction is done effectively, you can actually reverse the effect of this, and a woman can actually restore her ovulation back again. I have mentioned it tangentially, but I will mention it again now, that severe loss of weight can actually also trigger ovulatory challenges. Somebody who has been weighing 90 kg and suddenly you lose weight from 90, you crash to 50 kg or 60 kg or less. So severe weight loss. And this comes when you see people who have cancer situations or other situations like anorexia nervosa and other things that can actually cause extreme loss of weight. It could result in anovulation. And that's where extreme exercises play a part. So you must watch there is a balance of weight that you need to, and that's why monitor your BMI. BMI is what we call body mass index. Using your weight and your height to calculate the body mass index. Normal body mass index, 19 to 25, is very important. And if you are above that body mass index, and you're running in the 30s and in the 40s, that's something you need to monitor appropriately and know that this is not what it should be. And when you're below that, you're bordering on also on this extreme weight loss, it can affect your ovulation. Now, having said all this, let's go to what are the treatments. I will approach it in a few ways. I will approach it in few ways. One is to identify the cause of this problem, and you do certain investigations. Let me say that in identifying the cause, the first is the menstrual history. For us to actually assess ovulation, we look at your menstrual history, your cycle length, the irregularity, and every other thing. Like I said before, if you are a young lady or if you're a married woman and your menses is coming every month, 28-day cycle, 30-day cycle, and it's regular and it's happening, then it means that you're ovulating. So that's one way we can actually say for sure that this woman is ovulating with a regular cycle. But once your cycle is irregular, this month is 21 days, another month is 30 days, another month is 50 days, another month is that irregular cycle. It simply means that your ovulation is not happening as it should, and it calls for attention. Once there is amenorrhea or oligomenorrhea, I said amenorrhea is the absence of the menstrual flow, and the oligomenorrhea is prolonged cycle. The first thing to do when a young lady comes into the hospital and is worried, I don't know if I'm ovulating or not ovulating, and I can't see I'm not having my menstrual flow as expected and every other thing. So there is a period of amenorrhea. The first thing we do is to do a pregnancy test to check whether it's pregnancy or not. Because for every other treatment you're giving, you want to rule out pregnancy because that's actually your target. You want to achieve a pregnancy. So you don't want to destroy a pregnancy that has been achieved, thinking that you're treating it. So you take that precaution. The next is to do the fertility hormone profile. You do all the fertility hormones and the thyroid hormones, which is the FSH, the LH, I've mentioned there, the follicular stimulating hormone, the luteinizing hormone. You do the estrogen, the progesterone, the prolactin. And of course, in certain situations, you add the thyroid hormone panel, and then you add this anti-Mullerian hormone, AMH. So these are the things that we'll do. Once you've done all this, they will give you all the information you need. Sometimes you may need to do the androgens, especially if the woman shows signs of hirsutism or virilization. Then you have to also check the androgens, which is the testosterone, the androstenedione, and the rest of others to know whether they are elevated, because they can also affect what is happening. Simple pelvic ultrasound of the pelvis, particularly the transvaginal ultrasound, identifies the ovary very well and can give you, that's what we use in assessing the antral follicular count, and can give you a good idea what the state of the ovary is, because that's what we also use in monitoring the growth of the follicles. So pelvic ultrasound, transvaginal ultrasound, very useful and very effective. So these are simple assessments that you can do. Hormone assay, fertility hormones, thyroid hormones, anti-Mullerian hormone, and then also run the pelvic ultrasound. These two evaluations can actually clinch most answers to challenges with the ovulation, because you'll be able to assess the ovary. You have assessed the hormonal pattern. You have also assessed the clinical appearance or physical appearance of the ovaries using the ultrasonography. Today we have the 2D, 3D, 4D ultrasound. So there's nothing you want to look at the ovary. We can also even do the Doppler and see the blood flow of the ovary and every other thing. So you can assess all these things. So I'm assuring you that medical science can actually assess these things fully and give you answers to the challenges you're having, and you'll be sure what your next step will be. So doing this good evaluation is very important, because once you've done that, your situation would have been analyzed and you'll be able to say, this is what you have. I repeat it again. The solution comes when you know the answer, or when you know the cause of the problem. And I will say, if you have ovulatory factor, these are the things you do, and you find out the cause. And once you found out the cause, then we'll move into the treatment. First is to look at what if treatments that you can give by reversing some situations that the woman is exposed to. Number one is if it is issues of weight, diet, and the rest of others. You can do the nutritional adjustment and be able to achieve adequate weight gain or be able to lose weight, whichever side of the coin that it's involved. So, of course, if there are thyroid disease, hyperprolactinemia, I've mentioned if it's hyperprolactinemia, we have drugs that you can give so that you can reduce the prolactin level. And of course, simple method of assessing that this prolactin level is very high is if there is milk discharge from the breast. And once the treatment is given, this can easily be taken care of. If there are medication-related causes, you remove whatever medications that are the offending medications, and the condition will be taken care of. And these are steps you can take to correct situations that can be corrected. Having corrected these situations, we can also go to another aspect where we are now looking at when these ones, you've done all this and you're still not achieving your ovulation, the next step we'll move into is to stimulate ovulation, ovulation induction. And there are several levels or medications we can use to achieve ovulation. The simplest of them all will be our friendly letrozole or clomiphene citrate. I know why I mention it is that because it's a common thing. But any pharmacy shop, anywhere, that's what everybody will start with. You are not experiencing ovulation. They give you these drugs. Even so many, will I call it, even ordinary people know about these medications, and this seems to be the first line to say, take this medication and see whether you can have your ovulation or not, and every other thing. So, but this acceptable. But let me warn that we don't use these medications for more than 6 cycles. When you have used it for up to 6 cycles and you are not achieving the result, then you stop and know that there must be other things, and some other things have to be done. So it's not a lifetime medication that you now be on this medication and continue on it, because there are side effects or there are consequences for abuse of these medications. If these medications have not worked, we can take it to another level. We have injections that we can use to also stimulate ovulation. That's why we talked about the gonadotropins, the FSH and the LH. In a combination, they call it the HMG, human menopausal gonadotropin. So these hormones are already available in the market, and we use them regularly. The FSH, which is one that stimulates the growth of the follicles, they are available in the market, and you can actually use in injections. These all comes in injectable forms. The FSH and the LH, in their combination, the HMG and the rest of others. And these medications are there, and we can use it and achieve and stimulate ovulation, and the woman will achieve ovulation. This is very important, and that's to tell you that at any point in time we can actually stimulate ovulation to any level using these medications. These are also the medications that are used in assisted reproductive technology to induce ovulation or to stimulate the growth of the follicles so that we can harvest as many follicles as possible. So you see that ovulation induction is a science that is well established, and if you have not been able to achieve ovulation, we can, using these medications, help you to achieve ovulation and at any level. So this well established, and it works. And so that's the next treatment we can offer you. When you have achieved that ovulation, we combine it with what we call timed intercourse. If, for instance, the treatment we are trying to do is to help you to achieve a pregnancy. So when ovulation induction has been done and you achieve that ovulation, you combine it with timed intercourse. What do I mean by timed intercourse? You will be given a time to meet with your husband, exactly when that ovulation is occurring, so that you can achieve the pregnancy. Because the end point is for us to achieve a pregnancy. Remember, we are talking about causes of infertility, ovulatory factors. And if these are ovulatory factors, we want to see how we can overcome this challenge of an ovulation. So if we're able to stimulate the ovulation, you must connect that ovulation to a sexual intercourse so that the pregnancy can arise. Of course, one method of it is timed intercourse that I've mentioned. The second aspect of it is now going into, if it is not timed intercourse, we now move you to the next level, assisted reproductive technology. So you can see now, ovulatory problem. You start by finding out why. If it is correcting lifestyle changes, you do the lifestyle changes, reduce your weight, change your diet, and the rest of others, so that you can actually get back to your ovulation again. So that's the first level there. Or use simple medications, tablets, clomiphene and letrozole, any of them. Use it and you can achieve the ovulation again, of course. And you combine that ovulation with timed intercourse. And when you do that, you can actually achieve the pregnancy you're looking at. If these ones have failed, you can now move to that next level we are looking at, which is assisted reproductive technology. And this is very important. We have two levels we can think of: the intrauterine insemination. When that ovulation has been achieved, you can actually combine with intrauterine insemination to still achieve the pregnancy. Intrauterine insemination is to process the sperm and inject the sperm inside uterus at the time of the ovulation, because we can actually track the ovulation once we are doing stimulation. Track with ultrasound, we call it follicular tracking, and then you know when it's about to release. I must mention that when you do this stimulation of the ovary, you add HCG trigger so that it will help you to trigger the ovulation, and then you can plan your time intercourse very well. Or we can also plan the intrauterine insemination. Besides the intrauterine insemination comes the in vitro fertilization. So for most women, particularly those who are at the brink of depletion of their ovarian reserve, so they can now talk about assisted reproductive technology and use donor eggs. So at the extreme of cases where the ovulation has ceased completely. And that's why menopausal women who have actually stopped menstruating and who have actually stopped ovulating, 50-something years, 60-something years, can still have that hope or that conviction that they can actually achieve a pregnancy. What do we do in this situation? They now use donated eggs. So that, apart from stimulating your own ovary and getting your own eggs, harvesting the eggs and fertilizing in the laboratory by assisted reproductive technology, we can actually also, for those who have their ovulation has stopped completely, use donated egg. And with donated egg, you can actually fertilize with your husband's sperm and achieve a pregnancy. The baby is transferred into the womb of the woman, and the woman will carry her pregnancy and deliver. My oldest mother from assisted reproductive technology now is about 57-year-old woman. And of course, that's what happened. She had a donated egg, fertilized with her husband's sperm, and these things were processed in the laboratory and transferred into the woman's womb, and she carried her baby, and today she's a proud mother she's carrying her baby satisfactorily and happily. So that's why I'm telling you that menopause is no longer a cost to you, that you have stopped ovulating, or that even you have premature ovulation. That is not a death sentence. You can actually have received donated eggs and fertilize with your husband's sperm, and you can still achieve a pregnancy again. So even if you're the husband and you're listening to me at this point in time and you're planning to divorce your wife because you said her own time has passed and she doesn't have any eggs again to provide for you and everything, let me tell you, that is not an indication for a reason for you to ask her to leave. If you love her, all you can do is to access assisted reproductive technology, have donated eggs, and fertilize with your own sperm, and the woman will carry her pregnancy and deliver with joy, and your family will still be intact and your love will continue. So that is assisted reproductive technology for you. And so every range of ovulatory challenge, every range of problems associated with ovulation, anovulation, irregular ovulation, and even depleted ovarian reserve and menopause can actually be solved through ovarian stimulation or use of donor eggs, and with assisted reproductive technology, your pregnancies will come. So what are we succeeded in saying? That with assisted reproductive technology, every challenge with anovulation will be taken care of and the problem will be solved. And that leaves us with the final option, which is to consider adoption. When every other thing has failed, you can also adopt a baby. And when you say to yourself that adoption is not an option for you, I have made it clear to you that with in vitro fertilization and donor eggs, you you can also achieve your pregnancy and have your baby and be happy with your life. So today, if you have listened to me and one way or the other, you know that you're having challenge with your ovulation, it's not a death sentence. With ovulation stimulation, with assisted reproductive technology, every problem that you have with your ovary will be sorted out and you will still have your baby and you will still have your pregnancy. And if you follow the steps I mentioned and have the evaluations and everything, I'm assuring you that by this time, about this time next year, you will carry your babies and your life will be a glorious life and you continue to give praise and thanks to God. That is our message for today. And you join me again next week Monday as we bring you another series talking about next week Monday. We'll be talking about something that will be also very interesting to you. And we'll visit challenges that will come from the uterus, particularly uterine synechias, uterine fibroids, and the rest of others. We'll see how much of them we can cover up next week, and we'll continue in that series. So we're going to consider uterine factors, and may take us 1, 2, or 3 series to handle that. God bless you, and thank you for listening. I will take up your questions that have come on the platform. If you have not, please, you can actually type on the comment section, put up a question there, and I will go through the question and answer you. Thank you.
I have a few questions. Can a woman experience menstrual cycle?
Yes, you have mentioned that. Can a woman experience menstrual cycle? I said yes, and not ovulate. That means she will experience irregular menstrual cycle. The regularity of the menstrual cycle is determined by the ovulation. So once there is ovulation, the menstrual cycle will be regular. But when there is no ovulation, what happens is that we have breakthrough menstruation. So after 2, 3, or 4 months that the endometrium has so much accumulated blood and the endometrium has so much developed, it goes into what we call withdrawal bleeding. And so the woman will still see it as a flow, and you can still take it as a menstrual cycle. But at that point in time, it is not a normal menstruation.
Some of these questions I think you've already addressed, but just for the purpose of reading them out, someone is asking if a woman isn't ovulating, can ovulation be induced with medication?
Yes. The answer is yes, ovulation can be induced with menstruation. I've taken time to explain induction of ovulation and giving you the different levels that we start from tablets, we have injections, and we can also take it to the extent of even assisted reproductive technology. So ovulation can be induced and induced successfully. So when you're not ovulating, please visit a gynecologist who is well trained in these areas, and I tell you, your ovulation will be restored.
Just for want of time, we'll just take all the questions. Someone is asking, please, what are the drugs for high prolactin levels? And also, will I still get pregnant when I freeze my egg?
A very good question. Will I still get pregnant when I freeze my eggs? I missed out that aspect completely, but I'll mention it now. Particularly women, we are having cancers coming up in young women now, and they are going to take cancer therapy and every other thing. Such situations, they can actually harvest their eggs and freeze. And because cancer therapy, the chemotherapies, the radiotherapies, they affect the ovary. Most of the time, they knock off the ovary or they kill off the ovary. So you can actually harvest it and freeze it. And when you have finished this therapy and you're declared cancer free and you've survived it, you can actually take back your ovaries and use it to achieve pregnancies and everything. So it is possible, and it's happening now. That's one of the processes that we do for people who are in this bracket. There are also other set of people. I've had clients who will be in their youth, 30 something years, and they still have pursuing a career, and they say, look, I'm not ready to marry now. Maybe marriage will come up later. If you're in that bracket, instead of you marrying at 40 something and then your ovaries cannot work again and you have to go for donated egg. If you still want to use your own, then when you're 30 something, you may have to harvest your ovaries or harvest your eggs and freeze them. And when you are 40 something and you are married and they are not working again, you can actually go back to what you have frozen. So Preservation, we call this ovarian preservation. Ovarian preservation is something that is happening today, and it's a well-known therapy or well-known package in medical circles, and it can be extended to anybody. So it's possible.
Finally, what can I do to stop painful menstruation?
Very good. It's a very good question. Let me say that painful menstruation in all situations is not it's not bad. Menstruation can be painful at the very beginning, and particularly for women who have not conceived for the first time. It simply shows that it's the flow of blood and through a tight cervical orifice, and it generates that pain, and so that's dysmenorrhea, primary dysmenorrhea. In most situations, this is primary dysmenorrhea. And primary dysmenorrhea could not be a problem. Where we experience issues, or you know that there are pathology, will be secondary dysmenorrhea, menstruations that become painful after a period of time. Commonest among them in the causes of this painful menstruation will be endometriosis. And that's why we also say that every young girl and every married woman who is having painful menstruation, particularly one that didn't start from the beginning of the menstrual flow, suddenly develops, check, go and have an assessment to know whether you have endometriosis. Endometriosis is very important, and it's if it continues and it's not treated and it's not handled, it reduces the ovarian reserve, and of course reduces the ability of the ovary to produce follicles subsequently. So that is also a fact. So for treatment of painful menstruation, if it is a straightforward primary dysmenorrhea, painkillers is enough to handle that, or also for us to consider a way of actually inducing ovulation in such women, and these things can actually take care of these challenges. But if it is a pathological dysmenorrhea, you must look for the cause of that painful menstruation. And I've given one good example, endometriosis. Things like laparoscopy can actually look into the abdominal cavity and make that diagnosis. So a good number of times you may have to be subjected to ultrasonography, transvaginal ultrasonography, to look at the ovaries and look at the cavities very well. And where that has not given the answer, pelvic diagnostic laparoscopy and chromotubation can also give the answer. So these things are things that can be sorted out, and you will have your life and you live your life very well. Thank you. So in having taken these questions up, you can also type any other question you have on the platform. We'll take our time and still answer your questions and give you, it's not just answering your question, but give you direction so that you will know where to go and how to receive help when necessary. Somebody have asked about drugs to use in treating galactorrhea or stimulating the ovary. I will advise you to visit a gynecologist, and these things will be tailored to your need. Everything is tailored to your personality. We assess you and treat you accordingly. So go and visit a gynecologist, and your treatments will be tailored to your personal needs and every other thing. So there is nothing like a general medication that will serve everybody and take care of everybody. Even the dose will be independent, specific to yourself and to your condition. So on that note, I will thank you for listening, and God bless you. And remember, about this time next year, you will carry your babies. If you listen and follow the instructions that we've given you today, God will bless you. Amen.